What's the hardest case I've ever had to do? That's a great question. I think one of the hardest cases that I can recall was also one of the least serious cases. Sometimes little facial lesions, we sometimes call them ditzels, I don't know why, can represent real artistic and surgical challenges. And so taking off like a mole or something like that off somebody's face, especially when it's purely elective, carries a lot of risks. And I can think of one patient that we actually filmed and will provide that footage where we are trading off a small pencil eraser sized mole on the upper lip for a scar. And doing that has to be really calculated. And the patient we're going to present here was a Japanese woman, young, pretty, with healing tendencies that lead to kind of like bad scarring, especially on the body. The face tends to be a more privileged area for scarring, but here, let's just show you. So, like many procedures, mole removal can be performed wide awake, and patients are generally given some degree of sedation. And prior to doing any numbing or any sedation, I take a lot of time with a fine marker to make sure that my markings are perfect. Because if you numb something, then mark, it's like it's going to be distorted. And so, at this center, all routine, measures are taken to, ensure patient safety and everything like that. And we start off by numbing and allowing that numbing to settle in, and then we typically will apply some degree of a sterilizing agent to make sure that all bacteria are cleansed. This not only prevents against infection, but even when there's not an infection, if you have some sort of bacterial colonization, it can lead to inflammation, which leads to worsening of scars. So like most operations I perform, I'm very careful about, my surgical technique, and even the angle of the bevel that I use is calculated. This is something called an A to T plasty. You can't just cut out a mole like a circle, because as you close it, there's too much tension on any one point and you're going to get a wide, ugly scar. So in this case, I'm trying to make the incisions as long as possible, because there is a trade-off in plastic surgery that the longer of a scar, the longer of a closure, the more you get to share tension on any individual point. And so by creating this ellipse alone, you would have an improvement over a circle, but then the ellipse is going to cross over the white to pink junction of the lip. So how do we stop the ellipse without distorting the lip? We will translate it to a secondary transverse ellipse in the form of what's called an A to T plasty. So after taking the skin off the muscle that opens and closes your mouth, we then basically will perform a layered closure. Just like sharing tension across the length of an incision, we will share tension across the depth of an incision as well. And by minimizing tension on any individual point of a closure, not only will you have a less chance of having wound breakdown, but you'll also have a prettier line that you get as a result. Another thing that I did in this patient, taking very special care to make her scars look as good as possible, is to perform a technique called mattress sutures. So rather than just putting a interrupted or individual sort of one-by-one stitches, I placed a very careful and specialized type of stitch to evert the wound edges so it actually pouts outward at any given point. Here you see a horizontal mattress followed by a running stitch along the white and vermilion junction of what we call the Cupid's bow, or the white roll of the upper lip. I know all these things sound kind of daunting, and these are big words, but it just goes to show you how much thought is put into something that seems so trivial. But get this, even when you do all these things, even when you have meticulous technique, you still can get really scary early results. And this is what really kind of scared me about this case. We use laser therapy to minimize the scar even further. We took the stitches out as soon as humanly possible, less than a week post-operatively, and then the scar still was red and raised and unsightly for a while. It's hard to believe at 1 week when it's already almost invisible, but as we continue to follow this patient, the whole area got scary and red. And while this is a little bit unsettling at first, we know, based on our experience, that all these red scars and brown scars tend to fade. 2 weeks after surgery, she looked worse than before. 5 weeks after surgery, she still was red. It was over 2 months and you can still see this redness. But give it 3 months, now it's starting to fade out. And nowadays, you can barely even see the scar in a close-up selfie without makeup. This is how patients heal, and all of these extra steps and patience that we have for this type of closure pays off in the long run. This reminds me a lot of a very similar case in another young, beautiful woman who had a lesion. I think it was on her right side upper lip versus her left. And it was there for most of her life, but to me it kind of looked like cancer. So to take that off was a lot easier for me to do because first of all, she had better healing tendencies. Second of all, I had some clinical suspicion that this was a cancer of some type. But I treated it equally seriously because when you do that, when you take off something, a mole off somebody's face, and you trade it for a scar, that scar could potentially, as we've seen here, be worse looking than the original mole. So these things take surgical skill, very careful planning. We have strategies to minimize scarring and to expedite the healing process, and patience both on the surgeon's and patient's behalf. And when you hit a home run, sometimes you just hit a home run. Here's the other case. Thank you so much for watching. Please subscribe if you haven't already done so. And we look forward to answering any questions you may have on facial lesions or anything plastic surgery related.